take the stick. We're going to talk about our favorite topic, IgA nephropathy. Enjoy lunch, and we're looking forward to your questions at the end of this session as well. Thank you.
Thank you so much for getting us going. It's wonderful to see all of you again and to again talk about this unusual topic that we haven't been discussing much of, IgA nephropathy. I don't know if Professor Mariani is still in the audience there. I'd say shame on you for saying that you love FSGS, the best glomerular disease. I would say these are all our children, and we have to love them and respect them as individuals. So all glomerular diseases are wonderful, primary and secondary. It's just that IgA nephropathy's got the most action and the most to really focus your attention on now. I hope that all glomerular diseases will have the same attention soon. So let's look at a little bit more about where we are with IgA nephropathy in 2024, and then we can really dive into targeted budesonide, Nefecon, and really see where and when we should use it, again, with love and respect. So moving forward, this is disclosures for this communication. Again, this part is sort of non-branded slides. These are my own slides, so not so much influenced, but Calliditas is committed to education and transparency, and hopefully this program will demonstrate that. But again, things that hopefully we all appreciate now is IgA nephropathy is coming up to its sort of 55th anniversary, being described based on the development of immunofluorescence. We could then see that IgA was in this mesangial proliferative glomerular disease, so it can be termed IgA nephropathy, often with co-deposits of IgG and C3. Again, we already knew it was frequently recurrent in transplant patients just a couple years later, early in the 1970s, when not so many transplants were being done yet. Again, this is clearly the most common primary glomerular, I can't say glomerular nephritis, imagine that, in the entire world. And again, this amounts, at least locally, to be in the United States, to represent about at least 150,000 folks with 4,000 to 8,000 new cases per year. And as you know, there's huge variability region by region, where the rate is much higher per person in Asia than it is in very low areas like in Africa. But also the outcomes vary, the presentations vary. So we have to know that patients do have differentiating presentations and differentiating risks. Again, it is identified as a mesangial proliferative glomerular nephritis, and then the only way we can make the biopsy today, the only way we make the diagnosis is by biopsy, demonstrating dominant or co-dominant IgA deposition, generally in this mesangial pattern. So how do our patients do? This is an evolving story even to this very day, because I'd say it's a little bit controversial. When I designed this slide, which is probably 15 years old, I would say overall in a population of patients where we could detect every single individual with IgA nephropathy, as is done in Japan, or in some parts of China, where children are screened, get a biopsy if they have any non-urologic hematuria, that if you follow patients for up to 30 years, maybe 5 to 10% progression is what was suggested, okay? But however, if you diagnose patients based on the presence of persistent symptomatic high blood pressure, reduced GFR, proteinuria, suddenly the outcomes are tremendously worse. So proteinuria, really patients, 30 to 40% of them will come to end-stage kidney disease over 20 years. And again, I did update this slide more recently because newer data show that in some cohorts, like every biopsy patient in the UK, selected for either proteinuria greater than 500 milligrams per day, or a reduced GFR less than 60 mils per minute, 1 in 2 of those patients will suffer kidney failure just in 10 years. Okay? If they already have abnormal kidney function, then 50 to 70% of them will lose kidney function over 20 years. And again, if you do have cohorts you follow, not for 10 years, not for 15, not for 20, but then 30, more of them will lose their kidney function. And same thing with transplantation. There we can sometimes, by doing proactive biopsies, we can make an exact diagnosis of recurrence. Usually the first decade goes very, very well, with only 1 to 2% of patients coming to kidney failure over the first decade with transplant recurrence from the IgA nephropathy. But in the second decade, 10 to 20% of patients will lose their transplant if they get recurrent IgA nephropathy. So what's causing all of this? We've sort of simplified the world a little bit with a 4-hit hypothesis, saying that these are the events that occur in the majority of patients, with relatively good evidence for this emerging from places like Alabama, Paris, France, and from Tokyo, saying that these hits that are necessary but not adequate to get clinically important IgA nephropathy are the first hit, that you have some genetic predisposition that allows you to respond to stress, usually antigens, in mucosal surfaces, and have a sustained production of mucosal IgA, of galactose-deficient IgA, such that your serum levels are higher than they would have been. And then a second hit can come along, saying that if you have prolonged elevated sustained prolonged galactose-deficient IgA levels, your immune system is going to recognize that more than you typically do, so you'll have elevated anti-IgA antibodies, which most typically are IgG antibodies. And therefore, hit 3 occurs, that you have circulating immune complex of anti-glycan antibodies and galactose-deficient IgA. And finally, those have to, both by specific binding to mesangial receptors, mostly the transferrin receptor, and by concentration, non-specific clearance in the glomerular mesangium, you end up with mesangial immune complex. So those are the 4 hits. Now, I would argue that's not sufficient, because there are, by some autopsy series, 5 to 10% of us who have mesangial deposition of galactose-deficient IgA and immune complex, and IgG as well. And those patients do not, or those individuals don't all get clinical disease. So even though this is the 4 hits that allow this to occur, it's the inflammatory response in the glomerular mesangium and signaling to the podocytes and the tubular interstitium that lead to the clinical phenomenon of hematuria, proteinuria, and eventually fibrotic inflammatory changes that degrade kidney function. So again, this is just another cartoon that we created, saying again, if you're genetically predisposed, you activate your mucosa, you allow for B cell development, maturation, and sustained populations of antibody-producing cells, then your galactose-deficient IgA goes up. You can have an anti-glycan response, likely with other pools of B cells and plasma cells, and then you get accumulation of this immune complex in the glomerular mesangium, leading to inflammation, and both cellular inflammation, complement activation, and then to the clinical signs of IgA nephropathy. So again, some of these biomarkers can be reliably shown that you do have elevated galactose-deficient IgA levels, and that you have elevated IgG autoantibodies in patients with IgA nephropathy as compared to healthy populations. And so these are biomarkers that are helpful and move towards diagnostic inferences and prognostic inferences, but are not approved, validated biomarkers to this date. And again, as I said, the outcomes in IgA nephropathy are getting lots of attention, because I think we're moving away from the idea that this is a rare, slow-moving disease, that, hey, you were diagnosed, you've got a 90% chance of doing well over 30 years, to more and more evidence from the RADAR group, from the Kaiser Initiative in Southern California, from a nationwide survey that was done in the United States of primary insured individuals, that the prognosis is a little bit more bleak. Again, when you're diagnosed because of proteinuria, hematuria, or reduced GFR, your clinical course looks more like this, whether you're a child diagnosed or an adult. Child's in blue, and adults in the more pink fuchsia color. You can see that there's really much more progression than we would like. Again, in adults, 50% needing renal replacement therapy in the RADAR consortium, and even for children, about a third of them succumbing to renal failure in just 10 years. And then on the right-hand side, just looking at different ages and just showing, again, the younger you are, the more time you have for follow-up, the more likely that before you die, you will require dialysis. And they went further with these heat maps, again, saying that, again, the more apparent GFR loss you have, not surprisingly, the greater it is that you're going to have renal failure in your lifetime. And again, this is indeed modified by your age at diagnosis, because if you're diagnosed age 60 and you only live 20 more years, you're going to have less chance of developing renal failure. And again, the paradigm here is that virtually all of the patients who are typically diagnosed at age 20 or 30 who have active disease and who are losing kidney function by greater than 1 ml per minute per year, which is the average loss in anybody over age 30 to 40, that you're going to expect to be on dialysis in your lifetime. And so that's a rather bleak outcome. And again, for most patients you diagnose in your clinics, half of them will have to face transplant or dialysis within 10 years. And again, proteinuria is still a huge determinant of that. The greater your proteinuria at diagnosis, and more importantly, the greater your sustained timed average proteinuria, the faster you're going to arrive to dialysis or transplantation. But it's not only proteinuria, because what the RADAR group also clearly points out, and again reproduced by these other cohorts that have been published, is that those individuals with lower proteinuria, if they show other risks, such as a reduced GFR, and not studied in this cohort, if they have active glomerular lesions or tubular interstitial lesions, then they're still at substantial risk of progression to end-stage kidney disease, even within 5 or 10 years. So don't see a proteinuria at 0.8 grams per gram and say, oh, that's fine if your creatinine's 1.6. You're going to do well, because clearly those patients are still having at least 50% loss of kidney function, and instead of 10 years, it's 15 years. So again, these data and other cohorts really cry out that there's a need to identify IgA nephropathy early and always, because if we don't identify the patients, we can't intervene and do them any good. So we have to find them early and really call out for more universal screening of your analyses, especially albumin to creatinine ratios, hematuria evaluation, really think about blood pressure and changes in creatinine a lot more aggressively than we did before. When we have only RAS inhibitors and you say, oh, patient's on that, that's one thing. But we have many more treatments, a much more refined approach. And so we have to find the patients and have to be able to treat them more aggressively. So again, long-term outcomes are generally poor. Again, within their lifetimes, patients diagnosed with the disease are not going to escape without dialysis unless they die early. Again, the mean age of kidney failure or death in the UK cohorts, only 48. That's, the heart of protective lifetime. So that's not when we want them coming to end-stage kidney disease. And even patients traditionally thought of as low risk with lower proteinuria still had substantial risks for kidney failure. So the thing is, please consider the risk overall, and having things like the International IgA Nephropathy Risk Calculator allows you to do better to look short-term at 5 to 7 year risk, but that's only the beginning. You have to constantly think about whether you've reduced risk or not. And very clearly, across different cohorts that we're having developed, including short-term 2 to 3 year follow-up studies, slightly longer, looking at some of the testing data, the SGLT2 inhibitor data, we can see that there's this very, very substantial losses in the bottom line, that regardless of that population studied, that these GFR loss rates are ranging from the lowest to an aggressively treated population of about 3 mils per minute to the highest of about 6 mils per minute. So that's sort of an optimized, well-treated patients on RAS inhibitors plus SGLT2 inhibitors plus therapy to say, all right, that's where we're left. So we're going to have to do better because these are all numbers well above the 1 mil per minute per year where patients can be diagnosed and expect to live their lifetimes without transplant or dialysis. And fortunately, multiple therapeutic strategies are undergoing investigation or have completed their phase 3 studies and are now available to us. And they align with the pathophysiology of the disease. So, starting with HIT1, we can look at GI-related lymphoid tissue targeted therapies and go upstream and say, how do we get to that tissue and stop the increased galactose-deficient IgA from persisting? We can do that targeting the mucosa directly with targeted steroids to that site. We can go upstream and inhibit BAFF and APRIL pathways and think about other B-cell modifying therapies as well. And we have programs coming along. We can move further downstream and try to inhibit complement activation. And there's multiple pathways going on there. And again, big news pending today about perhaps a first complement inhibitor approved in IgA nephropathy. There is moving downstream ways to further inhibit kidney damage and fibrosis, again, by really maximizing RAS inhibition, SGLT2 inhibitors, looking at endothelin blockade, and maybe soon aldosterone blockade and GLP-1 agonist therapy may add to our armamentarium. And again, other therapies, like I said, other B-cell modifying agents, other ways to suppress antibodies, other ways to clear out galactose-deficient IgA or immune complexes are all undergoing early evaluation. Again, the natural course of IgA nephropathy is one where there's persistent deposition of immune complex into the kidney, a persistent drive for inflammation, which leads to the injury that we see. But if we delay therapy, then there's more and more focal glomerular sclerosis, global glomerular sclerosis, more and more tubular interstitial inflammation and tubular interstitial fibrosis, and that becomes proteinuria chronic kidney disease, which again, we all are trying to manage more effectively, and we do have more tools, but the idea is stop those nephrons from getting irreversible damage while we can, and think upstream and utilize agents early, and it only can come with early diagnosis and aggressive intervention. So you have to think all the time about how these independent factors, inflammation versus scar, are contributing to your patient's presentation. Okay? And again, one theory, again, could be that those autoimmune mechanisms, very specific to IgA nephropathy, your greatest opportunity to intervene is early in the disease course before there's abundant and overwhelming scar formation in the kidney. Okay? Otherwise, you're treating what we're doing now with diabetic kidney disease is just very late stage interventions. Okay, so that's how I wanted to set the stage, because now you'll hear about the single approved agent, which I think is phenomenal progress and something that we should grab on and utilize frequently. But I guess we're allowed to have 5 minutes. Is that what you want us to do for initial questions and answers, or shall we go to the end? Let's see. I think it's best we just go all the way to the end, and you guys can ask questions about pathophysiology and disease state, and then you can ask about therapy as well. So you could see I wasn't prepared to think that, but thanks for your attention for this section. I will turn this over to my partner, and I look forward to some probing questions about what you think about pathogenesis, intervention, and treatment pathways in IgA nephropathy in just a little while. Thank you.
Just here. Hello, everyone. So I'm Dr. Reddy. I'm a clinician and a nephrologist. I practice in Midland, Texas. Not many people might have heard about Midland. It's in between El Paso and Dallas. Any of the fellows here? Any nephrology fellows? Wow, there's not a single fellow. Okay. So when I joined nephrology, the one thing they used to say is, when are you doing dialysis? That was a single question, right? So in the last 5 years, it's been exciting time to be a nephrologist. We have so many new players. It's been exciting times. We are not the same old guys, use the same binders for 50 years, same guys use the same ACE and ARB for 30, 40 years. Now we have a lot of new players in the treatment paradigm shift, especially in our autoimmune world. There's been changes happening every 6 months, which is exciting for us. So this is a talk which is sponsored by the company. Let me see if I can make the slides words. So when they called me and said, can you give a talk on this? I said, yes. I did not realize I'm following Dr. Lafayette to this talk. They tricked me. Now, this is the first, I've done these few talks, but this is the first time I'm going to be talking on the slides, which is basically the studies done by Dr. Lafayette and his colleagues. So we look up to these papers for us to guide us in clinical sciences. In nephrology, when we look up, these are some of the giants in our field, which has helped us to take care of these sick patients. So what are we going to talk about? We are going to talk about two things: a new drug in the IgA treatment, which is Tarpeyo, and review the phase 3 trials, some results. So Tarpeyo, which is a budesonide, which has been in the world for many, many, many decades. It's been in use for every reason, good and bad reasons, forever. During the COVID, whoever thought, in my area, they used to call it a silver bullet for budesonide inhalers. So it's been in the market, but the company came up with a delayed release capsules, which is targeting Tarpeyo. That's how the name. Tarpeyo is targeting Peyer's patch, which is the gut-associated lymphoid tissue, which is the main culprit thought about for the IgA pathogenesis. So this is the only and the first FDA-approved treatment for IgA nephropathy, for delaying the progression of CKD or renal loss. So like I said, it's a corticosteroid indicated to reduce the loss of kidney function with IgA nephropathy, primary IgA nephropathy. It is approved irrespective of proteinuria levels, which is very important. Like Dr. Lafayette mentioned, early intervention is what's necessary. Now, in the past, we used to say, okay, wait for the proteinuria to worsen, maximize the ACE and ARB, give the, all the supportive therapy, and if the proteinuria worsens, we had few options. But now we have this, which is approved only for IgA nephropathy. It's the first drug. So how does it work? Like I said, when the company thought about getting this molecule, they thought about a delayed release mechanism where it can work in the distal ileum where the highest concentration of Peyer's patch is located. So if we stop the HIT1 hypothesis, basically what we thought is you have the galactose deficiency IgA coming from the gut-associated lymphoid tissue, leads to the cascade of downstream activity that leads to the nephron loss. So if you think about it, the first step is reducing the galactose deficiency IgA. If we can target that, will it translate into a meaningful clinical use? So they came up with this once-a-day capsules, which are designed to release at appropriate pH in the distal ileum. The dissolution study has confirmed that the TARPEO is different from the other entry-coated budonicides available in the market. Like I said, TARPEO is a modulate potential biomarkers by acting on the gut and kidney axis. In the gut, in the ileum plays a big role where this drug is delivered to the distal ileum where it works on the mucosal B cells, reducing the production of galactose deficiency IgA molecules. So when they did these trials, they did this, they looked at IgA deficiency galactose, does it really work? And what you can see is these are not commercially available. We don't do it in our clinical sciences, but this could be something coming in the future. What you are seeing is at baseline, patients with IgA, galactose deficiency IgA, which is IgA A1 at baseline, treating with TARPEO for 9 months, what you are seeing is significant change in the IgA abnormal molecule, which confirms the mechanism of action. So based on this, now we'll look at the trial data to see if it's clinically relevant. Does it make a meaningful use in our day-to-day clinical practice? Does it affect the patients with IgA nephropathy? So what did they do? They chose multicentric randomized trial. Study design was patients were screened and patients were already on a stable, tolerable doses of ACE and ARB for more than 3 months who had IgA nephropathy. So there are 2 groups, one with the placebo, one with the TARPEO, treated for 9 months. Interim analysis was at the primary endpoint at 9 months, and then followed the same patients for 2 years to see how it affects off the TARPEO. So primary IgA, the inclusion criteria, they took any patients with a biopsy-proven IgA in the previous 10 years who had a proteinuria of more than a gram or a urine protein creatinine ratio of 0.8, GFR between 35 and less than 60. They're all on maximum tolerable doses of ACE and ARB in the previous 3 months at least. Exclusion criteria, they excluded patients with kidney transplants, obviously liver cirrhosis because budonicide is metabolized in the liver through the cytochrome 450 subclass A4. So they didn't want liver cirrhotic patients with severe exposure. Considering it's a corticosteroid, they excluded the poorly controlled diabetics. In the patients who were treated with corticosteroids in the previous 3 months or immune suppression medications in the previous 12 months. More than 50% of the patients were less than 45 years of age. Why is this important? Because like Dr. Lafayette was mentioning, based on the radar data and everywhere, even normal-looking IgA nephropathies can lead to ESKD over a period of time. So diverse populations were considered. They didn't want to have one ethnic group over the others. So baseline in the study characteristics, patient had around 2.3 gram proteinuria. At baseline PCR of 1.2 and 1.3, GFR 56, stage 3A, kidney disease. Patients with diabetes were more on the TARPEO side compared to the placebo. Significant proportion of patients had microhematuria. The diagnosis median time was around 2.5 years. So what did they find? So far we said there is a molecule, Tarpeyo, which is a corticosteroid. They made a capsule which is delayed release, expected to work at the ileum. We saw that it does reduce IgA abnormal molecule. Now, does it really translate into clinical world? So what did they find? They found the 2-year GFR data showing that there is a more than 50% difference between the placebo and the Tarpeyo group. And if you look at the graph, interestingly, until the patient was on treatment, the GFR was preserved. There was some decline, but still at the end of 2 years, there is a significant difference in the GFR between the placebo group and the Tarpeyo group. So what about the PCR, right? Proteinuria. So you could see that there is a significant reduction in proteinuria at the end of 1 year. Even the treatment was there for 9 months. You could see that there is a significant effect for 3 months of the treatment, and it continued until 2 years. There is a significant difference between the proteinuria in patients with placebo and Tarpeyo. So if you did not pay attention to whatever I spoke in the last 15 minutes, this slide is the take-home slide. Think about it. You have a patients who are coming in our offices with IgA nephropathy in the mid-20s, who have some proteinuria. You want to treat something, this is where we are targeting. Like any corticosteroid, safety information. Keep an eye for hypercortisolism, like anyone. But considering this drug, even though it is locally acting, which has a significant first-pass metabolism, more than 90% is metabolized in the first-pass metabolism, still you need to keep a close eye for hypercortisolism and adrenal axis suppression. So don't try not to treat with cirrhosis and liver abnormalities. Keep a close eye when you are treating because of the cytochrome 450. Anytime we give a steroid, what is the big question we have? The number one question we see in our office is infection risk. So we always worry about the infection risk in our glomerulonephritis patients, including IgA. So keep a close eye. I'll come to the study, what they found in the study, but keep a close eye for that. The other corticosteroid effects. So we are looking for weight gain, the hypertension, diabetes, osteoporosis, things like that. Drug interaction, I mentioned earlier also, this is metabolized through the cytochrome 450 subclass 3A4. So make sure when you are treating with antifungals, anti-HIV medications, transplant medications, be careful with the interactions so that it may increase the systemic exposure to Tarpeyo. So avoid grapefruit juice is one of the things I tell. Pregnancy, in pregnancy, the steroids are found to be safe, but not with this Tarpeyo. We are not, the study was not included Tarpeyo, but you can suggest by extrapolating the data from all the other things, steroids should be relatively safe in pregnancy. So like I said, we have this drug which is locally acting, less systemic exposure. Does it really pan out in the adverse events? What they found, which is significant compared to the placebo, is some of this hypercortisolism, which is weight gain, around 2.2 pounds, some peripheral edema, hypertension, acne, no serious infection risk. No serious infection risk between the groups, and this study was done without any prophylaxis with for the PCP or anything. That confirms that the systemic exposure of steroids is much lesser with the Tarpeyo. So patients who did have some blood pressure issues, weight gain, diabetes, they're all resolved within 3 months after completion of the study. So A1C was not significantly altered between the groups. Tarpeyo versus the placebo. Weight gain was around median of 2.2 and returned to baseline after the discontinuation of the therapy. No bone prophylaxis was given, but they did not find any new osteonecrosis. It's a once a day on an empty stomach. You don't want anything to alter the pH because you are trying to give a Tarpeyo which is about to work in the distal ileum. So at the end of the therapy, try to give it, reduce the dose to 8 milligrams a day for 2 weeks, then stop. In summary, what do we know? We have a new drug approved for IgA. It's the only drug available which works on the IgA nephropathy patient, showing clinical significant improvement in the proteinuria and the eGFR. It is relatively safe. Most of the side effects were expected and no serious adverse events were noted. It is the only immunomodulating, considering it targets the distal ileum where you expected to have the abnormal IgA production, and the trial did show the reduction of abnormal IgA in the paper. So I conclude. I'll leave some time for questions. Thank you.
Hello.
Yeah.
You answered part of it at the end of the slide that the tapering dose by the end of the course of the therapy will be just to go from 16 to 8, then we safely can stop it immediately, right?
Correct.
Okay. Is there a study, maybe you present and I missed it, is there a study that compare head to head between it and the regular steroid, systemic steroid therapy?
No, not yet.
Okay. Thank you.
Thank you.
Thank you so much for the presentation. I have a question from one of our virtual attendees, and she's asking, what's the difference between other type of budesonide that we have, and if we can prescribe that for IgA nephropathy?
So like I said, on the dissolution studies, they found that the Tarpeyo with the triple bead technology, it's designed to be working at the distal ileum and the right pH. So when they looked at, it's never been studied for IgA, for the inflammatory bowel disease, whatever they have done. But when in the other paper where they looked at the dissolution study, looking at different categories of budesonide, there's a difference at the pH where it's released, the capsule is dissolved and releases the triple bead.
So again, the formulation is different of the different types of budesonide, and this is the only one that is designed and proven to truly target Peyer's patches.
Thank you.
Thank you.
Thanks to both for very clear talks. Coming back to Richard's point about the need for early diagnosis and immediate treatment, in the United States, I understand that the median GFR at biopsy for IgA is less than 60. So how do we achieve what you are looking for? Should we be working together to get screening in high school, in college, in workplaces to detect IgA earlier, much as appears to be successfully done in Japan?
Yeah, so I obviously strongly endorse that idea. I think, we have in the United States, we have the United States Preventative Healthcare Task Force, and they have said it's not cost effective and reasonable to screen for kidney diseases by means of urinalyses or routine urine albumin to creatinine ratio testing, except in very high-risk populations, such as people with hypertension, people with diabetes. I'd certainly love that to be immediately changed to first-degree relatives of anybody with kidney disease, because there's a high yield and a very clear yield to find kidney disease, including glomerular disease, in that population. I think certainly the albumin to creatinine ratio is fairly specific for kidney disease that needs further evaluation. I'd love for children and people transitioning to college and for internists to do routine UAs looking for hematuria. Again, the presence of hematuria, especially in young women, obviously leads down a path that's often not rewarding. So it does get complicated for sure. But I think in the context of any change in blood pressure, symptoms, fatigue, swelling, we've got to screen a lot more actively. And again, time after time after time, microscopic hematuria is ignored and not followed up upon, in young people especially, where it's unlikely to represent cancer. And therefore, I think we can do a much better job.
I have something to add to this. In the community where I practice, most of my IGAs might have had 1 or 2 urgent care visits, 1 or 2 ER visits, where we need to emphasize the UA as the EKG of the kidney. If it's a EKG, if it's abnormal, everyone freaks out, from the ER nurse to everyone else. When it's an abnormal UA, the only thing that America thinks now is a UTI. Unfortunate training needs to be improved upon, where we can say, if there is a protein or blood in the UA, it's not just UTI. You need to think about glomerulonephritis. You have to follow up. They need to get some kind of mandate. When it is EKG, they make it so obvious that you go to the cardiologist if there is abnormal EKG. But when there is abnormal UA, a course of ciprofloxacin, 2 weeks later, the patient does not show up anywhere. 3 months later, comes back to the ER, now the creatinine is 5. I find this 1 or 2 cases every year who are diagnosed in the mid-20s with either IgA or with any other glomerulonephritis. I think there is a need to improve the UA as the EKG of the kidney.
Thank you very much. We're going to take a question from Dr. Glassok as well.
Yeah, 2 great talks. Thank you very much. I'd like to comment on Dr. Lafayette's talk very briefly. As I get older, I get interested in history and etymology. That's a common phenomenon of aging. So I went back and looked at some of the history of IgA nephropathy not too long ago. I just want to point out to the younger members of the audience, when Berger and Inglé first described IgA nephropathy as we know it today, the title of the paper was Intercapillary Deposition of IgA/IgG. Berger gave equal weight to the IgA and the IgG in the deposits in the kidney of the disease that he described. Now, many years later, we dropped the term Berger's disease and replaced it with another term. But we didn't continue the philosophy of Berger and call it IgA/IgG nephropathy. A little more difficult to say, but it would have been more accurate to call IgA nephropathy, as we know it today, IgA/IgG nephropathy. Now, why is this important? Well, you know, IgA is the antigen. IgG is the antibody. Richard showed you the diagram. The antigen is HIP1. It is necessary but insufficient for the disease. The second hit is the antibody, IgG, antibody to IgA, which is galactose deficient. That is necessary and a requirement. You do not get any disease unless you make the antibody. It's been clearly shown because relatives of patients with IgA have elevated galactose deficient IgA antigen in their blood, but they never develop IgA/IgG nephropathy unless they have some trigger that generates an antibody. So actually, if we're thinking about treatment, particularly curative treatment of IgA nephropathy, the focus should be on the antibody and not on the antigen. That's my own personal view. The same that we do in membranous nephropathy, and the same we're likely to do in the future with minimal change disease if it turns out that antinephrin antibody is the cause, and so on and so forth. The question is, how can we best reduce antibody production in IgA, IgG nephropathy? Well, first of all, we'd like to know where it comes from. Likely, it comes from bone marrow, germinal centers and lymph nodes, including Peyer's patches, and probably peripheral circulating B cells that are programmed to make antibody. In this case, plasma cells. Remember, the source of antibody is plasma cells. Well, many drugs do affect the antigen part. I'm sorry, I'm giving a lecture. I should sit down. I am so interested in the history, and I think the fact that the name did not incorporate the IgG has sort of lost our interest in IgG, and I think antibody needs more attention.
I think other advocates might say it might have been better called IgA C3 glomerulopathy if you're thinking that way, because the prevalence is about the same. And if we had any more time, which we unfortunately I don't think we do, but we'll see if our host for the meeting gets to say something. I'd also ask, because those autoantibodies to IgA include IgG, but also IgA, and very interesting, a lot of IgM as well. And even though IgM is not seen by our pathologists often, it does look by a couple papers to be an interesting additional prognostic factor. So.
Yeah, thank you, Dick. We can create a special session at the beach later this evening on IgA nephropathy. But I wanted to take the opportunity on, and piggybacking off what Bruce said about coming together as sponsors with working together in screening these patients earlier. So I would like to use this opportunity to call for the sponsors here in the room to come together, help us build an alliance for IgA nephropathy, for early screening in the community, not the pre-selected patient that come later once the creatinine has risen, the disease has progressed to the nephrology clinic, but going out there in the community, screening, helping us support initiatives to screen early, to follow up this patient, to build a real-world evidence study in the real-world setting to see what is the prevalence out there, how it is looked like when patients are not pre-selected into these studies. That will help identify patients for early treatment opportunities. It will help patients for trial opportunities, and it will help create a registry for control arm studies, phase 4 studies, and so on. So maybe that's
I echo that as loudly as possible, but I will tell you optimistically, all the sponsors involved in this GlomCon meeting are already heavily engaged in at work to get that educational and political message across to society that we have to do a better job in early screening, definitive diagnosis, and prognostication. So bravo, I agree with you.
One last question from Dr. Fogel.
This is a comment on this discussion about screening. So in my used Robbins textbook of pathology, which was already then ancient and older than the published year in terms of the knowledge, it said that Berger's disease was a disease with microscopic hematuria of no clinical significance because the follow-up wasn't long enough back in those early days. I also learned that in Japan, IgA nephropathy had a wonderful prognosis. And then I learned that was because it was so common that screening UAs were done at multiple steps during school, and it was followed up with biopsies based solely on microscopic hematuria. And it's very rare that we get renal biopsies from just microscopic hematuria unless there's a family history or great familial anxiety. And a whole bunch of patients who had very minimal reason to have any progression were biopsied and identified as this great prognosis IgA nephropathy cohort. So I find it very unusual that I'm saying this, a renal pathologist. I wonder what the intermediary steps are that we could take from screening and detecting microscopic hematuria, because certainly we're not going to biopsy all of those patients. And we don't have established wonderful studies yet for biomarkers. As we heard from Richard yesterday, we can measure the antigen. That doesn't give us a precise diagnosis. We don't have reliable assays for the antibody, and we're working on it. So I want to just end with a little interaction I had with Ron Falk eons ago. One of my first ASN meetings, I already knew Ron Falk, and I'd heard the rumor that he was presenting on IgA fibronectin aggregates in the serum in patients. And my colleagues in nephrology at Vanderbilt said, Agnes, you're going to be out of a job. We're not going to do any biopsies in IgA nephropathy. Ron Falk's data are going to be so exciting. And I saw Ron Falk, and I'm sure many of you know it, he can be fabulously persuasive, almost like a preacher, having you come to, whatever holy deity you want to come to. I saw him and I said, Ron, tell me about IgA fibronectin aggregates. And he looked at me very seriously and said, Agnes, it's an amazing test. It cleanly, completely divides the population into two groups, those that have IgA fibronectin aggregates and those who do not. So we need to do better than that. I think we need to screen, but we need something in between going to the kidney biopsy to find the patients that are going to need the treatment. So I just wanted to go in a very unusual way saying, don't biopsy everybody with microscopic hematuria. That will possibly cause harm. Thank you.
Thank you very much. Any last comments?
No, I was just going to hopefully say for you that ushers in, there's several more talks about diagnosis and management of IgA nephropathy upcoming, and they will delve into biomarkers, diagnosis, and utility. So thank you for segueing to that.
Thank you very much. Great discussion.